The Retrospective Registry of Patients with Mechanical Heart Valve Study is a chart review-based study of patients receiving mechanical aortic and mitral heart valves at the Hamilton General Hospital up until 2019. These patients were predominantly followed at the Hamilton General Hospital. However, a cohort of patients were included who had follow-up through the Niagara thrombosis service at the St. Catharines General Hospital site of Niagara Health. Mechanical heart valves are important life-saving devices, and currently VKA therapy is the only indicated anticoagulant to maintain their proper function. VKA therapy has limitations such as inpatient variability, interactions with food and other medications, and requires frequent blood testing and dose adjustment to maintain the INR in the target range. This can be very difficult, and patients with poor INR control are known to be at higher risk for adverse outcomes, including stroke, valve thrombosis or related complications, along with bleeding complications. There is a large unmet need for alternative antithrombotic treatment in patients with mechanical valves and poor VKA control. A trial with the direct thrombin inhibitor dabigatran was stopped early when patients with mechanical valves had an unacceptably high rate of thrombotic complications compared to the standard warfarin cohort. It is currently not known if anticoagulants like the factor Xa inhibitors or potentially the newer factor XIa inhibitors, which possess an alternative mechanism of action, would be acceptable alternatives to Coumadin in this patient population. This retrospective registry was designed to try to quantitate the rate of outcomes such as all-cause stroke or valve thromboses, along with major and non-major clinically relevant bleeding outcomes in patients with poor INR control. Patients were described as having poor therapeutic INR control if their time in therapeutic range was less than 40% over at least 6 months duration or on at least 6 consecutive INR measurements. This cohort was compared to patients with a TTR of between 40 and 60%, which is considered average control, and those with greater than 60%, which is considered optimum control. Data were gathered from the Hamilton Health Sciences and Niagara Health cohorts through the DAWN clinical software program, which is a computerized INR monitoring system based at the Hamilton General Hospital. At the time of presentation, data have been collected and are currently being processed and analyzed. It is hoped that the outcome of this particular study will begin to quantify the hemorrhagic and thrombotic complications related to that patient population, specifically with poor VKA control in mechanical heart valve patients. This will serve as a basis for potentially allowing the design of future trials using alternatives to VKA therapy that will have more predictable pharmacokinetics for such patients with the potential for less complications. There are also potential implications for the care of such patients in underserviced areas of the world where INR monitoring can be challenging, and more predictable therapeutics would be expected to have even more impact on complication rates. This study is consistent with the Niagara Health 10-year strategic plan for developing innovative strategies to help improve outpatient care and healthcare delivery.
Hi everyone, my name is Eva. I'm a third-year medical student here at McMaster University. It is my pleasure today to present our poster titled Persistent Sciatic Artery Aneurysm, Presenting with Limb Ischemia, a Case Report and Literature Review. So to begin, let me tell you a little bit about what a persistent sciatic artery is. So a PSA is a rare congenital anomaly with an incidence of 0.025 to 0.04%. The sciatic artery is a continuation of the internal iliac artery that exists in utero and typically involutes during embryonic development to form the gluteal arteries proximally and the popliteal and perineal arteries distally. However, when the femoral artery develops partially or absent, the sciatic artery can persist to form a persistent sciatic artery, which is typically large and tortuous. Although this is a rare finding, it is clinically relevant as approximately 48% of PSAs develop aneurysmal degeneration, which can result in a pulsatile mass, distal embolization, sciatic neuropathy, and rupture. So in our case, we will present the case of a 54-year-old gentleman who presented with acute limb ischemia secondary to a persistent sciatic artery aneurysm. And in terms of treatment for these patients, it does depend on the symptomology as well as the classification of the PSA. And options include open surgical, endovascular, as well as hybrid options. So moving on to case presentation, we have a 54-year-old male who presented to the emergency department with severe left foot pain associated with coolness, pallor, and paresthesia for 4 days. A CT angiogram demonstrated a 4-centimeter PSA aneurysm with distal embolization. The patient was treated with a hybrid procedure of an endovascular PSA aneurysm embolization, as well as an open femoral popliteal bypass. The patient recovered well and had normal ABI as well as palpable posterior tibial pulses 6 months postoperatively. In addition to the case report, we conducted a literature review of all PSA aneurysm cases from 1965 to 2021 in PubMed. And in total, we found a total of 101 patients with an average age of 65.8 years old at presentation. There's a slight female predominance of a 61.4%. And as you can see, most of the PSA aneurysms was complete, which means that the PSA was the predominant arterial supply to the lower extremities, as opposed to the femoral artery. In terms of presentation, there is a great variety, including gluteal mass, distal embolization, acute limb ischemia, claudication, sciatica, critical limb ischemia, and asymptomatic. So in terms of the management plan, there is not really a consensus in terms of the procedure, but most patients underwent an open surgical procedure at 46.1%, endovascular at 21.6%, hybrid options at 19.6%, conservative measures at 10.8%, and not reported in 2 patients. Most patients recovered quite well postoperatively with a limb salvage rate of 84.3% and forefoot amputation in 1 patient, below knee amputation in 1 patient, and above knee amputation in 2 patients, and not reported in 12 patients. So in conclusion, the PSA is a rare congenital anomaly with high rates of aneurysmal degeneration requiring interventions. Historically, they're managed with open surgical repair, but recent advances have allowed for endovascular and hybrid approaches with decreased postoperative morbidity compared to open repair. Our case report demonstrates successful repair of a PSA aneurysm presenting with acute limb ischemia using the hybrid option. And our literature review shows that most patients recover well postoperatively. Though there is no consensus for treatment due to the rarity of this condition. So thank you so much for listening to our poster presentation today. Please let me know if you have any questions, and you can see our references below. Thank you so much. Hi, everyone. My name is Eva. I'm a 3rd-year medical student at McMaster University, and it is my pleasure today to present to you our poster titled 30-Day Reintervention and Mortality Rates After Interventional Radiology Procedures in Niagara Health, a retrospective chart review. So to begin, we were interested in this research project due to previous research conducted in the United States showing that patient population composition and socioeconomic status could be important factors in determining patient outcome after IR procedures. Specifically, 30-day reintervention and mortality rates are good quality improvement measurements for outcomes after IR procedure. So we were interested in determining whether this association would also be found within Niagara Health System and whether the 30-day readmission and mortality rate at Niagara Health is comparable to those reported in literature as well as identifying possible gaps in care within the program. So in terms of our method, this is a retrospective chart review of patients who underwent IR procedures at Niagara Health between January 2018 to December 2019. The primary outcomes were 30-day reintervention rate, the percentage of patients who underwent another IR procedure within 30 days of their initial IR procedure, as well as 30-day mortality rate, the percentage of patients who died within 30 days of their IR procedure. So this is an interim analysis. In total, we were able to analyze 20% or 226 out of the 1,199 procedures and 219 out of 809 patients. So in total, 5,065 patients underwent 8,189 procedures between 2018 to 2019. So after excluding patients who only underwent one procedure, we had 1,613 patients, and excluding patients who underwent repeat procedures on the same day, which is most likely part of the same procedure, such as an angioplasty plus an angiogram, we ended up with 809 patients undergoing 1,199 procedures, which is a total reintervention rate of 16%. However, out of the 16%, we were interested in how many patients underwent a IR intervention for an unrelated reason or for a reason related to their first intervention. So we discovered that 4.5% underwent a reintervention that is unrelated to their initial intervention. So for example, someone could have undergone a pericocentesis and maybe had angioplasty later that month. And 10.9% underwent a reintervention that is related to their initial intervention. However, out of those, 8.2% had reintervention, which was not due to complication of their initial intervention, and 2.7% actually underwent reintervention due to a complication from their initial procedure. So this is only a preliminary analysis and subject to change in the future. Our next steps would be to complete analysis of all reintervention charts, calculate intervention-specific complication rates, compare intervention-specific complication rates to published literature, and identify issues in the IR care at Niagara Health that would be amenable to quality improvement interventions. That concludes our presentation. Please let me know if you have any questions, and thank you so much for listening.
Hi there, my name is Gracie Hodgson, and today I'm going to talk about factors that increase risk of falls among older adult inpatients. So just to define a fall, that is an unplanned event and somebody coming to the ground, obviously not on purpose, and multiple falls would be defined as 2 or more of these events per hospital visit. So falls are pretty extensively researched, and that's because of their prevalence. So especially if you're over the age of 65 in Canada, 20 to 30% of these people experiencing a fall each year. So they're very common and can result in decreased quality of life, injuries, and longer hospital stays. So our research focused on particularly multiple falls, and this was because, although still serious, a single fall might be a one-off incident, right? I could fall tomorrow and it wouldn't be a big deal and wouldn't be indicative of a major problem. But if somebody's falling multiple times, this calls attention to there may be an underlying issue. The hospital setting was also important because of the high concentration of health compromised patients. So fall may be more serious for this group, as well as the hospital has a lot of resources that they can use to prevent these instances, like staff and equipment. So overall, we wanted to compare possible differences in risk factors associated with multiple and single falls, as well as predict risk factors associated with multiple falls in this population. Our methods, we incorporated an epidemiologic cross-sectional design. So we had 2,580 patients, and they were split up into our multiple fall group, so people that had fallen multiple times, and our single fall groups. We had about 22% and 78%. So this was looked at over a 5-year period, and we used a logistic regression. So our independent variables are listed here, and we'll talk about those a little bit more. So here in table 1, we have our proportion comparison of patient fall characteristics. So the yellow highlights significant findings at the 5% level, and the red highlights whatever group was more common, or we had a higher percentage of falls happening. So the hallway, for example, we had a higher percentage of the multiple fall group falling in the hallway. This maybe was because increased foot traffic or wider hallways, whereas in a washroom, we had more people that only fell once having their falls in the washroom or shower. And this was because that patients might go on their own thinking that they can get there okay, or maybe really need to go and have a fall and then learn that they maybe should have waited for staff. So this also calls attention to systemic issues in the hospital with how busy our staff are, and that we're actually leaving room for a fall to occur or multiple falls to occur based on their workloads. And literature is mixed in terms of railings on beds. And we had more people falling multiple times where there were no rails. So this concluded that railings might actually be really good for fall prevention. Continuing on with this chart, we had standing and walking occur more often in the single fall group. So walking was common among, falls while walking was pretty common among both groups. But again, this may raise awareness to their vulnerability to a fall or risks for a fall. And if they fall once, they might be more careful or ask for assistance in the future. So we may be only seeing them fall once. On the other end, we have wheel and jerry chair users falling quite often multiple times. And this is likely because there's a lot to consider with patient transfers, chair maintenance, and things like that. A lot of practice and training needed from the staff. We also looked at level of harm and found that level 2 and level 3 were significant. So those that didn't incur any harm were more likely to fall again or multiple times, meaning that they probably didn't learn much from their first fall because it caused them no harm. On the other end, we had mild harm. So if an individual did incur harm, they were less likely to fall again, maybe because they were more cognizant of their risk factors. And here is our logistic regression. So using our variables as predictors of multiple falls, we found that calendar season and type of hospital fall were predictive risk factors. Calendar season was likely because of the warm weather. People want to get outside and are potentially more likely to fall. And age and location were not predictors. So our final thoughts is that hospital stays should be healthy experiences and important in recovery for everyone. We don't want to have another issue or fall. So this knowledge could be helpful in clinical practices as well as education and prevention strategies. Thanks for listening.
Peripheral arterial disease of the leg arteries such as the superficial femoral artery, the popliteal artery, and the tibial artery can lead to intermittent claudication and stenosis, which may contribute to chronic limb ischemia. To alleviate the symptoms of critical limb ischemia, patients commonly undergo percutaneous transluminal angioplasty with stenting, and occasionally without, of the superficial femoral vessel or the specific vessel that is affected. This angioplasty procedure disrupts the atherosclerotic plaque by displacing it radially. However, this can sometimes result in the stretching of the adventitia, thereby increasing the lumen diameter in the treated vessel. As we mentioned, stenting can also be consequently done for longer stenoses and occlusions. We conducted a single-center institutional retrospective analysis to evaluate the safety and efficacy of procedures such as the percutaneous transluminal angioplasty with stenting and without stenting of the superficial femoral vessels in all patients who had peripheral arterial disease admitted between 2015 and 2019 at the Hamilton General Hospital. Our main outcome was the primary patency rate, which was defined as the length of time that patency is maintained before any recurrent stenosis or repeated interventions for the superficial femoral vessel. Additionally, we evaluated outcomes such as the procedural success rates, rupture rates, fatal rupture rates, and determined risk factors of perioperative complications, such as hypertension, coronary artery disease, chronic kidney disease, and others. Patient demographics were extracted at the 1-month, 3-month, and 6-month intervals using standardized forms. Data was available for up to 38 months. Descriptive statistics were used to report the results that we found. During the 35-month study period, 71 patients that underwent a percutaneous transluminal angioplasty with stenting and without stenting of the SFA vessel were included. 14 of those patients did not get stenting, and the mean follow-up time was 1.84 years. We discovered that the mean primary patency rate was 1.46 years across all patients, irrespective of stenting. As you can see here in Figure 1, there is a noted decrease in patency rate over the months. This is a pooled estimate of both the stenting and non-stenting group. In Figure 2 here, we display the patient characteristics and the comorbidities that we've collected from them at the beginning. After running a regression analysis with the patient characteristics, we noted no correlation between any comorbidities and the patency rate. Our study also finds that there is no significant difference between the PTA and PTA with stenting groups in terms of primary patency. However, there was a noted difference between short and long-term outcomes for the alone and with stenting groups. For example, the PTA alone group had better primary patency rates at 3 months, whereas the patients who underwent a PTA with a stent had better patency rates at 6, 12, 18, and 24 months. In conclusion, we note this as stenting being shown to notably improve patency rates long-term in patients with PAD of the SFA. Overall, we believe that percutaneous transluminal angioplasties can be considered effective for the treatment of peripheral arterial disease in these patients, and our institutional analysis shows that stenting notably improves long-term primary patency outcomes in patients with peripheral arterial disease of the superficial femoral vessel.
Hello, I'm Katie Baker, and I'm here to present to you our project entitled A Review of Post-Intubation Analgesia and Sedation within Emergency Departments in a Multi-Site Community-Based Hospital System. I'd like to thank all of my co-authors who are listed on the slide below. I have no conflicts of interest to disclose. Now more than ever, with the strain on our hospitals and emergency departments due to the pandemic, ventilated patients are remaining in our emergency departments under the care of our ED physicians for longer periods of time. Although ED guidelines and post-intubation care are lacking, ICU guidelines support an analgesia-first approach to facilitate lighter sedation strategies. We know that early deep sedation of our ventilated patients is harmful and is a risk factor for delirium, longer ICU stays, and even mortality. Furthermore, awareness with paralysis is a real phenomenon and was reported in 2.6% of ED intubated patients in one study, a rate higher than that reported in the OR literature. This leaves us with a potential care gap for our ventilated patients. The primary objective of the study was to determine current practice patterns in the provision of post-intubation analgesia and sedation in community hospitals within Niagara Health. A retrospective chart review was conducted between April 2015 and December 2019 to identify all patients intubated in the ED. A random sample of 750 charts was taken to determine a sample most representative of current practice. Inclusion criteria were those intubated by means of rapid sequence induction, patients remaining in the ED for at least 30 minutes, and survival to hospital admission. Exclusion criteria consisted of those intubated for cardiac arrest, age less than 18, those intubated prior to the ED, and those extubated in the ED. Of the 750 charts that were reviewed, 487 were ultimately included in the data analysis once exclusion criteria were applied. Data analysis was performed by frequency to determine trends in type and timing of post-intubation anesthesia. Sedatives were considered medications without analgesic properties, most commonly propofol and benzodiazepines, and are represented in the top graph. Analgesics, most commonly fentanyl, are demonstrated in the bottom graph. One can appreciate that sedatives were given more frequently than analgesics in the post-intubation period, with 58% of patients being left without an analgesic on board. When we looked at the timing of initiation of post-intubation sedation and analgesia, one can also appreciate that there appeared to be a delay in the provision of analgesia, with a sedative being given at a median time of 12 minutes and an analgesic at a median time of 26 minutes post-intubation. Previous studies have suggested that the use of rocuronium, or longer-acting neuromuscular blocking agents, is a risk factor for delayed use of sedation. Use of rocuronium was also noted to be a risk factor in studies that looked at rates of awareness and paralysis, further supporting the need for early use of post-intubation sedation. Our study showed a trend towards delay in initiation of sedation with rocuronium use compared to shorter-acting agents. Overall, 85% of the patients in our study were given post-intubation sedation. This is actually a rate equal to or above that seen in the literature. However, only 42% of patients received an analgesic. There was also a difference in the timing of initiation of analgesia versus sedation, with an analgesic given at a median time of 26 minutes compared to that of 12 minutes of a sedative. Finally, ED length of stay post-intubation was a median time of 153 minutes, which has no doubt increased since the pandemic due to increased boarding in the emergency department, further supporting a need to master our post-intubation care. Our study does have some limitations. With its retrospective nature, we rely on accurate and complete documentation in the chart. Insufficient data in charts did result in 155 charts being excluded from the analysis. Furthermore, because the ED literature is lacking guidelines with regards to post-intubation care, there is significant variation in practice amongst providers, which can make it difficult for us to draw comparisons. In summary, current literature, mostly from the ICU, points to the benefits of an analgesia-first model of post-intubation care. Our study signals that post-intubation administration of analgesia is often insufficient or delayed. This highlights an opportunity for further review of practice and perhaps standardization of post-intubation care for our ED ventilated patients. Thank you very much for your time.